Good afternoon, folks. Thank you for joining us. You've logged on to Grand Rounds, sponsored by the Department of Psychiatry and Behavioral Sciences at the University of Washington. Thanks for joining us today. My name is Jed Thompson. I am the host of Grand Rounds. I'm also the uh, Associate Director of Communications for the department. So I welcome you. And before we begin, I want to give a few of our logistics. We'll go over some of the basics of our Grand Round series, and then we have a really interesting talk prepared for you today. So to start with, I want to let you know that today's presentation is sponsored by the Garvey Institute for Brain Health Solutions. We are also going to be recording today's presentation. So if you've really enjoyed the topic, we will have this posted on our archive on YouTube. It can be accessed through our website. We've got 10 years worth of archives videos on there, so take a look through those. Also, we will have a survey available at the end of the presentation if you'd like to give us some feedback. So as soon as the webinar closes, you'll see a link that'll take you to that survey. So if you have another minute or so after we conclude here today, we'd love to hear from you. We're going to try to leave a little bit of time at the end of the presentation for some question and answer. So we have that Q&A feature in the webinar activated here. So chat's there too. But if you have any questions, go ahead and type those into the Q&A. You can do that anytime during the presentation. We'll get those queued up, and then we'll go through some of those at the end of the hour today. And then I also want to let you know that next week we are not going to have a Grand Rounds presentation. So the next one is going to be November 14th, and we'll be joined by Dr. James Moreau for that one, and he'll be talking about uses of ketamine. I don't think that's the official title, but that will be the topic that will be covered on the 14th. So please join us for that one. And now, if we want to go on to the next slide, I am going to turn it over to Dr. Mark Duncan, who is going to introduce today's speaker. So Mark, I'm going to toss it over to you now. Floor is yours.
Thanks, Jed. And welcome, everybody. It's good to be here. And I'm happy to introduce our speaker for today. So Dr. Majid Afshar is a tenured associate professor in the Division of Pulmonary and Critical Care Medicine in the Department of Medicine, where he co-leads the Critical Care Data Science Lab for the Department of Medicine. He is also the director of the Learning Health System in the Institute for Clinical and Translational Research in the School of Medicine. He's part of the UW Health Informatics leadership team and has helped with the implementation and evaluation of emerging technologies in artificial intelligence. He helped guide one of the first real-time natural language processing implementations in healthcare practice for the clinical decision support and is leading initiatives to integrate clinical trials and operations for AI interventions. In addition, he is part of the pioneering work to deploy generative AI technologies, including large language models in health operations. As a physician scientist, his work is dedicated to the prevention and early identification of diseases using methods in clinical translational natural language processing. Dr. Afshar performs predictive analytics using AI with electronic health record data for screening, diagnosis of diseases in critically ill patients. He has hosted several national data challenges to advance the science and diagnostic decision support systems, and was appointed as a chartered member of the NIH Digital Health and Clinical Informatics Study Section. And so it is just a great honor and privilege to bring in Majid here to talk about bedside implementation of AI into the electronic health record for screening hospitalized adults at risk for substance use disorder. You know, we were talking at the beginning here about how for a long time we've been putting in data to our electronic health records. And it's really exciting to see how some of this data can be used with this emerging technology of AI. Majid is incredibly positioned to bring us this talk and just talk about some of the work he's done. So thank you very much, Dr. Afshar, for talking today and coming to us. And I will turn it over to you to present. So thank you.
Thanks, Mark. I appreciate the introduction. Mark and I go way back to medical school days, so it was nice to reconnect for this opportunity. So I appreciate the invite. So my talk is going to kind of focus in this unique area within AI as a whole field. As you guys may think of AI, there's many people may understand it differently. Within AI, there's machine learning. Within machine learning, there's deep learning. And there's some overlap from the natural language processing world and even the computer vision world. And so my talk today is kind of the overlap between natural language processing and deep learning. And this field has continued to evolve. This is what you guys now know as ChatGPT. And so the work I'm describing today is a little bit more of a focused task, unlike these kind of generative models that can do multiple tasks. But I'm happy to talk more about that as well if questions come up. The life cycle for an AI kind of intervention that I'm going to describe goes through multiple phases. And in my opinion, we really should be thinking about these AI software that are being implemented into our health system as interventions. And they really should go under randomized clinical trials, just the same way we do pharma or other sectors in the healthcare kind of paradigm. And so for this talk, I'll walk you guys through how we came through the model development and validation work, what we did for some of the human-centered design, getting at the human factors engineering and systems engineering approaches to implement the model, and some initial testing phases before we go on into a clinical study. In this case, we didn't do a clinical trial because it was a hospital-wide deployment, but it was more of a quasi-experimental pre-post design. And we're now actually in the post-market surveillance phase where we actually have a governance committee where I just had to present to yesterday for the one-year follow-up of how's it going with the model in the system. Now, the access to data and the development of models has gotten a lot more easier for folks. In fact, the software these days are largely plug and play, but we see hundreds, if not thousands, of publications on the next, deep learning model or prediction model, but less than 1% of those actually make it into translation for practice. And I think this is the leaky pipe effect that we realize, is that these systems are either not fit for purpose, or it's not really adding value. It's already doing work that's already being accomplished. And so there are a lot of reasons where the foresight's not there to identify the realized improvements that AI systems can potentially give. And I think the reason for that is we really need a team science approach. You can't just have the AI scientists and a clinician involved in thinking about this whole workflow. You need the implementation scientist, the systems engineer, the informaticist, the ethicist, your kind of stakeholders at the operational levels. So it can really require multiple stakeholders to achieve the success you may want. I'm going to describe this intervention as a clinical decision support tool, CDS. And so when I say that, I think the reason that I'm using that term, at least in my interpretation, is really to get at 5 things that are the 5 rights of CDS. And I'll tell you, both from the last slide, the leaky pipe effect, I've made multiple failures in my career and with my collaborators in trying to get to a realized model for effect. And here in this CDS approach, also, you'll see, in fact, in this use case, I've made mistakes as well. And so it's really getting the right information, to the right person in the right format, in the right channel at the right time. That really is, you may have the best model that has amazing accuracy, but if it's already showing something to someone that they already know, what's the point? Or if it's too late, or if it's going to the wrong person. And that is really the systems engineering and human factors component that I was talking to earlier. So for this talk, I'm going to kind of bring you guys into one of the use cases that's the title of this talk, which is screening for opioid misuse in the health system, and specifically in our acute care setting. As you guys, as Mark introduced me, I'm a critical care doc. I spend 20% of my time working in ICU, and then the rest of my time is running our learning health system and building AI systems. Now, for this use case, this was work that got funded from NIDA. This was an R01 of mine that we just finished the whole 5-year project. And the motivation was like, the United States Preventive Services Task Force does recommend screening for opioid misuse in adults. That's a grade B recommendation. And NIDA has actually built a manual human-driven screening tool called the TAPS tool, as you guys may be familiar. And the TAPS has that first initial phase of universal screening for all patients, all comers into that setting, and then the kind of follow-up risk assessment to get you at those who may actually have opioid use disorder for you guys to make a diagnosis. At University of Wisconsin, we don't have a formal screening program for hospitalized adult patients, and that's the setting we're focusing on. Furthermore, a lot of the information that may be collected in our intakes, right? You guys, when we do our H&Ps, we're asking social history questions, we're asking substance use questions, but they're never necessarily used for anything in many instances. And so there's a lot of information that's collected that's not acted upon in the electronic health record. While overdose deaths are now decreasing, and we're seeing, continuing changes in drug markets, The number of hospitalizations from the physical ailments of substance use, like wound infections, endocarditis, respiratory pneumonia, and asthma, those numbers are still rising. And actually, in the acute care setting, these are important touch points. And so these are issues that we deal with. And right now, at least at our, I don't know how you guys manage your addiction services, but at University of Wisconsin, in this Institute Department of Psychiatry, we actually have a Department of Family Medicine and Addiction Medicine division, and they run the inpatient consult service. And so we have an addiction medicine consultation service. It's been one of the largest, it is one of the largest and one of the oldest in the country, but it's an ad hoc service. So you kind of just, it's up to the provider or clinician to decide if they want to order a addiction medicine consult. And so there's selection bias there, there's sometimes delays, and we're not really tracking the epidemiology of our screening program in this instance. So my aims here, I wanted to describe to you how we developed and validated an AI-driven screening tool for this purpose, what we did to kind of get through the rigors of kind of getting at the performance metrics that would convince an operations health system or a governance committee that this is fit for purpose, and then actually evaluating in practice with a fully embedded EHR implementation. So let me start with the way we design this system to be not only fit for purpose, but also for sharing and generalizability. So like I said, this is focused on the inpatient setting. So these are looking at touch points in the hospitalization. In fact, we're looking to build a screening system. If you assume that average hospitalization is 2 to 3 days, can we identify someone that first day with the data that's collected on the first day, but then still give time for a few more days of the care teams to intervene? So in that respect, we only focus on the first 24 hours of notes from arrival. So from the time they come to the emergency department or direct admissions, these are progress notes, the nurse notes, HMPs. We don't care what the note type is. We're not interested necessarily in that. We're just saying, let's keep this simple and just throw at us everything that shows up in those first 24 hours, with the understanding that there's a lot of information in those notes, the admission notes, like I mentioned before, the social history and all these things. And this is a little bit more informative in terms of behavioral health that may not be captured in the urine drug screen and the issues with that, or some of the other lab tests or what we call structured data elements. Really, over 80% of the EHR is in this unstructured free text format. So there's a lot of opportunity to extract useful information out of these. And lastly, while there are human screening programs where you can run the TAPS tool or the DAST and audit for alcohol, you can imagine that a screener coming to the room may get different responses from a trusted provider or someone who's established rapport while they're taking care of the patient's immediate needs. This is just a list of all the different note types that may show up, right, in your EHR. But getting at some of these note types and within them, some of that information, like, you know, past medical history, seizures from quitting beer, paramedics found them down, the medications that were administered, you know, prior social history and things like that. Those are really kind of hidden in these notes in some ways, as they're not really extracted out for purpose. So when we designed the system, there was one other thing we wanted to do was bring this into something called a common data model. You know, there are nuances in how we document from region to region, and there are a lot of different terms that may change over time. And so how can we map these to a unified medical vocabulary? Well, the National Library of Medicine has a unified medical language system. And in fact, all the ontologies, if you guys are familiar with, obviously ICD codes is one ontology, but RX norm, SNOMED, LOINC, MESH, there's this text, these ontologies have this taxonomy where they actually can go up the tree and come to a final, what's called concept unique identifier, a CUI. So we actually use that, the CUI actually representation of the free text. So you imagine a note that has multiple mentions around substance use or risk factors. Those actually can now get codified and mapped to these concepts. And they can come from multiple dictionaries, from SNOMED, ICD, RX norm, and whatnot. So this is a screenshot of the National Library of Medicine's website where opioid misuse gets assigned a CUI ID number. And then there's multiple different versions of that. And within that, there's different kind of atoms. They all map up to this opioid misuse. So even though it may be set in a different syntax or with different versions or synonyms, they actually sometimes, most of the time will come back to this mapping. So why is that important? Because now we've somewhat simplified the process, right? We take all the different note types across all the text, which can be abundant, and we've concatenated them, brought them into a single document, and we've transformed them now into this codified document. So it's a string of codes that represent all the medical concepts. And what gets dropped out of that, there's challenges here because you lose some of the semantic, the context, right? Which is why language models these days, ChatGPT, excel. So there's certainly opportunity there. But this is such a focused task that we're doing that these medical concepts, I'll plan to convince you later of how they're still useful, right? And so we use this software called CTAKes, which is a kind of a processing engine that is open source. It's free. Some of our collaborators actually developed this out of Mayo a few decades ago. And we built this kind of codified document. Now this document is in a format that could be fed into machine learning models and deep learning models and AI systems. So now we come to the next step. Okay, well, we need to train a model that can identify cases that may be amenable for making a diagnosis and identifying the high-risk group. And so in this work, we actually went to a health system, one of the few health systems that we identified in the country that was actually manually screening at the time everyone that walked through the door for their adult hospitalizations with at the time, the DAS, the drug abuse screening test, with follow-up questions about opioid use and the audit. And so we took about, I think, 3 years of their data. And this is the kind of flow diagram of how we kind of organized the data and identified of all the hospitalizations that came through and those that got the majority of them receiving this universal screening and follow-up screening tests, then the categories of substance use. And in this case, we broke it up into 3 major categories: opioid misuse, non-opioid drug misuse, and alcohol misuse. And the reason we did it this way is alcohol misuse actually has its own, applications, which I'm not going to go into necessarily for this system. Opiate misuse was the one we were focused on, and non-opiate misuse, as you know, there's evolving kind of treatments still, and we don't really sometimes have the best treatment options for these folks. And so we wanted to have things that we could clearly identify in kind of groupings and then intervene on. And so this system is called Smart AI. That QR code actually gives you access to the full model, the trained model, which I'm about to go through. So it's open access, meaning it's publicly available, free to you guys to download the model and run it in your health system. Now that's easier said than done, but that's the case. And again, this was trained on inpatient adults at this health system using all the first 24 hours of notes. So they had the screen results as a separate kind of data domain with the screen positives and screen negatives, and then we had all the notes, which did not include the screen results. So how did we train the model then? Is actually we took all these notes, we transformed that into that codified document I described to you, and then we did something called supervised learning, where using all the data in those notes through a machine learning algorithm, we kind of learned what is a positive screen from the DAST and audit, and what's negative, and that we use 80% data to learn on that, and then we had this holdout test set to evaluate on. And in the end, we came out with 3 different categories, like I mentioned: opiate misuse, alcohol, and non-opioid as a yes, no for screen positive. So again, you have these like mentions in the notes of different terms that get mapped to these concepts. These concepts, in this case, what we fed them into this is a picture of what's a type of deep learning model called a convolutional neural network. Essentially, it just looks at all the different ways these words interact with each other. These concepts can potentially interact with each other. So imagine, millions and millions of interactions. In fact, this model for us had close to 15 million parameters in it, which is, at the time, was big. Now is really small compared to these hundreds of billions of parameters, ChatGPT type models. But it was easy, it was small, it's efficient, it's cheap to run is the key, and we can share it. It's trained on, even though it's trained on EHR data, it's fully de-identified, structured, coded data that we can easily share with others. Next step was that we wanted to validate this and see how it performed. So we looked at several metrics. One was discrimination. How well did it identify cases from non-cases, which in this case is what the AU, the receiver operating characteristic curve, does for us, as well as this precision recall curve. And so in this situation, we looked at not just the overall across all 3 categories, but for each category, how well did it perform. We did something called temporal validation, where we took the most recent data from that same health system as kind of the most recent practice and types of documentation and evaluated against that. And then we did something called external validation, where we went to another health system. Actually, we went from an inner city Chicago health system to a suburban with different demographics, different payers, different catchment area, and we then ran it on there. And if we're looking at just the opioid portion of this, you can see that it performed well. And so we were kind of happy with how the external validation went at this point. And furthermore, we then took that and looked at different cut points, thresholds, to identify what's the right sensitivity and specificity trade-off that we want to run the model at, so that it can give us clear cases of, yes, this patient flagged positive, no, this patient did not. And so when we did that, we're getting sensitivities of 87%, which is a good range for what you want for a screening test. The next thing we wanted to do is we went to our addiction medicine team and we're like, look, guys, this is what we're seeing in terms of what you could expect for number needed to evaluate, meaning these are the number of patients that will get flagged positive, that then, for every 1.3 patients, one of them will be identified as truly positive. And that would lead to about, given the number of hospitalizations we're seeing in our health system, 25,000 a month, a year, 25,000 a year, 2,000 or so a month. That comes out to about 26 alerts per 1,000 patients. And so they deemed that was acceptable for their kind of faculty and staffing as it was. We kind of looked at the absolute risk of this model and what was called a calibration plot here, where the middle line is kind of perfect calibration, meaning for what was observed for cases versus what the model predicted. You want to match up, and the dotted line is pretty close to matching up, and that p-value represents that it actually was not different than that line. And so the calibration here was good for us as well. And then we wanted to look across parity groups. Hey, we want to make sure this model is not going to stigmatize against certain groups. Maybe it was trained, we've seen this lots of times before. It was, just trained on a certain population, and then it kind of like is unfair to other populations. So this is just a snapshot, but we looked across multiple racial and ethnic groups. We used the area deprivation index and looked across different socioeconomic groups. And we looked at the false positive rate, the false negative rate, to ensure that there weren't major drifts or shifts that were going to cause us to kind of pick and choose folks unfairly. And the last thing we did, and what most folks should do in their rigor, is examine what is that model actually picking up on. And so there are methods in AI around explainability where you can build surrogate models to investigate the main model. And we did stuff like that here. And we're seeing the features pop up that make sense to us, right? There's face validity here. Like there's mentions of heroin, smokes tobacco daily, victim of abuse findings. These are all the medical concepts, those codes, and what those reference text for those codes. And so you can see that it was having good face validity for us as well. Okay, so at this point, we've done some of the work to kind of examine the performance metrics of the model itself, but that's far from the translation into practice. And so this is where we want to employ our learning health system, and we want to bring in more implementation-focused approaches and kind of looking at more downstream effects on outcomes rather than just the performance of the model itself. And so we, at University of Wisconsin, we call this research-grade analytics on an operational timeline. And so we really want to bring that rigor of research into clinical effective practice. And in doing that, the way we employed this with this use case was doing these rapid PDCA cycles, plan, do, check, act. And so the idea here is that, we identify a problem, we kind of look at it for a short course of time, come up with a solution, reiterate, see if it fixed, and then go do a few more of those. And so that, in some ways, is how you can get that implementation to go from a low fidelity prototype to a high fidelity system. So this figure is not, for those who are DevOps people or people who are engineers in our health systems, this is a great figure for them. But for our purposes, this is really just get at like the work that needs to go into implementation. It's not just the human factors, but there's a whole nother kind of IT stack around it, right? It's not simple plug and play. So in this instance, what I'm showing you here, and that QR code will take you to a paper that gives you the playbook on how to do this, along with some pseudocode from our engineers, is that we run an Epic. And so an instance of Epic at University of Wisconsin, we had to like take those notes out in real time from Epic. And so we use this data exchange system called Cloverleaf, using a health level 7 or HL7 kind of feed. That's step number one. We then push this up into our UW Health cloud system. In this case, we use Microsoft Azure. And in there is where we run that whole kind of CUI system, that NLP engine I was talking to you about earlier, to take the raw notes and put them into these concept codes and nicely organize them into a table ready for feeding into any type of model, whether it's this model or another model. And so that's step 2. Step 3 is we feed it into that model we trained that I just described to you called Smart AI. It spits out the scores, those probabilities. We have a threshold, identifies the screen positives. We then from there leave our cloud and have to go into Epic's cloud. And so this is a huge cybersecurity task for us because 2 clouds talking to each other with PHI is challenging. And from there, Epic can then bring it down to our local Epic instance, and it can populate a flow sheet, and that can be built into a best practice alert or OPA. So in summary, I hope I've convinced you some that we kind of did the due diligence here to develop an accurate model that had a workup to detection ratio acceptable for our workforce, looked at the absolute risk of that model to ensure it wasn't causing major issues at any given threshold. The bias and fairness was assessed. It had good face validity. So now we took that model, we wanted to register on clinicaltrials.gov. We wanted to build into our health system. The health system needed a screening system, so they wanted to just deploy this system-wide after meeting approvals and silent testing and with their governance committees. And so that was the direction we're heading in. And so in doing that, we went to, at University of Wisconsin, we had the Clinical AI and Predictive Analytics Committee, which is a group of experts, operational and research, that kind of helps to make the determination if something's fit for purpose for operational use and quality improvement. And so that's what this was. And then we did some human-centered design workflow with our implementation scientists on how to build this in the EHR so it pops up the alert in a way that's going to be used. We had to go through physician committees, nursing committees, our clinical decision support committee, and get approvals. It had to be built in, and again, like these PDCA cycles. So a lot of steps to kind of go from what we developed as as potential software to kind of implementation into our health system. And so that PDCA cycle that we did, the 6 weeks iterations, we did 2 of those. And the first one of the issues that came up was that it was taking too long for the alert to fire. And so we wanted to, the way we fixed that is we weren't actually including all the ED notes, we realized. So we actually moved the latency up from the BPA and had the ED notes included. We noticed that the screen tool was able to actually detect patients sooner in that way. Cycle 2 was the addiction medicine service was wondering, like they were getting consult requests, but there wasn't a clear reason other than a BPA fired. And so they wanted to include reasoning into that. And in addition, they are also worried that like some of these patients, this was a good opportunity to kind of start, managing some of the withdrawal that patients may experience. And so with the BPA, in addition to making a recommendation to consult with the addiction medicine service to make a diagnosis, potentially start treatment, why not then also, if you think patient is has unhealthy opioid use, start the COWS scale, the clinical opioid withdrawal scale, so you can manage any withdrawal symptoms that may arise. And so this is the actual BPA that I have to go into a couple of iterations with design and human workflow analyses with our implementation scientists. This is what pops up. So any given patient, let's imagine you're working in a hospital, you're a hospitalist or on the wards, and you're taking care of a patient, you go open the record. If they had screen positive in the background with that whole system I just described to you, this pops up and alerts you. And it pops up for anyone that opens a chart on that patient. So that, right patient, that 5 rights thing I talked about CDS, giving it to the right person at the right time. We may have been giving it to too many people, but it was better to give it. At the time, we were still figuring out how to get it to the right person, but it was at least getting it to the right person plus others. So with that being said, you can see this is what the OPA looks like. It gives a little description. It allows you to make 2 orders right away, consult the addiction medicine services, and start the COWS score. If you don't, what are the reasons that you don't want to use it, and go from there. Next was running this as a clinical study. And so what we did in this quasi experimental design is pre-post. We had a pre-implementation period matched for season across 2 different years and about 34,000 encounters. And then we had the system that was kind of everything else being the same with the addition of the AI screener to augment these providers was the post-implementation period. From there, we were able to identify who received addiction medicine consultations using, again, fully EHR embedded workflow. We could do that versus those that didn't. And then from those who went on to receive, what was the actual intervention received? So if the BPA fired, of those addiction medicine consult services, was it due to the BPA or not? That's not shown here, but that's what we looked at. And then if it did fire and an addiction medicine consult was ordered, we only counted it if the patient was seen by the addiction medicine team with a note that was dropped in the billing code and the intervention. And the intervention, we looked at medications for opioid use disorder, but then there are lots of other interventions that these folks can do, right? They can give harm reduction services, naloxone dispensing, outpatient treatment referral, motivational interviewing. So there's lots of different things that can happen beyond just medications for opioid use disorder, as you guys know. So this study was published in Nature Medicine, and what we found across that study period was that lots of BPAs fired. It was across 157 hospitalizations during that 6-month period. And there was a median about 10 BPAs per hospitalization per patient. So it did fire multiple times. Of all the consults that were received in that post period, 13% of them were due to BPA. Of all those BPAs that fired, 22% of those led to addiction medicine consultations with interventions. Only 3% were recorded as inappropriate, which kind of followed suit with kind of what we saw as false positives. Of all those BPA fires, 27% of those led to cows being started. Cows not just being ordered, but with scores being recorded as well. The primary outcome, so the way we designed this study was not that we were trying to show that the AI system was better. We were more interested in showing that the AI system is no worse. So we actually did a non-inferiority design as a primary outcome for having a consultation with intervention. And the reason for that is really that we're trying to demonstrate automation and scale with AI. And so we want to show that's no worse than a human-only workflow. And in this case, we met the non-inferiority margin, so it was less, the p-value was significant for that. The rates of consultations with a denominator across all hospitalizations was 1.35 versus 1.51%. The last author on this paper is a health economist. And so he was able to help us look at the fixed and variable costs of the system. What did it take to stand up this whole kind of AI infrastructure? And then the variable cost was staff time, counseling, medication costs that actually went with the clinical practice, and the per patient incremental costs. And what's interesting is that in our secondary outcomes, we actually noticed with the AI screener in place a reduction in 30-day readmissions. And we, again, this is an observational design, so I certainly respect the potential residual confounding. The rest of the health system did not see a change in readmissions. We tried to adjust for demographics and payer mix and everything else. We looked at different fixed time periods. It kind of stuck. We saw a reduction in 30-day readmissions. And given that there's this number of readmissions avoided, the incremental cost was actually a cost-saving effect with this AI system, accounting for the whole paying for the system and the incremental costs that came with it. So part of this R01 was that we also had a second health system that was to deploy this AI thing. And so two things about the second health system. One, this was the health system that we designed the AI software at, so that we developed it using their data. At the time, they were manually screening everyone. And so that's why we wanted to test AI automated screening versus manual screening. If you remember at University of Wisconsin, it's ad hoc consultations. There's no formal screening program. Whereas this was one of the places that did have one. But by the time we were ready to run this, COVID had happened and staffing had gone away and the manual screening program fell apart. They just didn't have the human labor to do it. And so that I mean, it kind of speaks to the point of why we may want systems like this to help overcome some of these human labor constraints that can be better used elsewhere. But at the same time, so we wanted to use it as a comparator, but what ended up happening is it ended up being kind of they had some manual screening with, social workers still being involved as needed, but not a formal screening program. So we still ran it that way. And that's what this is showing at the second health system. Otherwise, kind of the similar workflow where we had the smart AI system implemented. Now, the difference between their implementation and ours was another issue, right? I showed you guys this whole kind of engineering setup, IT infrastructure. It's no small feat to bring these things in. It cost us almost $400,000 to get this thing stood up. This other health system was like, we need a lot more money because we don't have the capacity or internal expertise. We have to outsource some of this stuff. So getting it stood up as a fully EHR embedded system was not feasible for them at the time. So we used the research coordinators. We fed the model, the results to the coordinators from the lab, like the research side, and then the coordinators would then play the role of the screener automation in the EHR to then reach out to care teams to say, hey, your patient was found to be at risk. Would you consider a consult order? So not a fully embedded EHR system, which is one of the biggest disadvantages. But they were looking across all three categories then, not just opioid misuse that we identified as a gap in our health system. They looked at alcohol screening, opioid misuse screening, as well as non-opioid drug use. And this is what it shows in the consort flow. The hospitalizations, this was over a course of a year. They had 33,000 adult hospitalizations. The AI screen and the smart AI saw all these 34,000 hospitalizations. You can see non-consult patients and those that didn't go on to receive an addiction medicine consult. Of those, there were smart AI was positive, but didn't lead to those consults in 526 cases. Of those, only 55 of those were deemed as false positives. A handful of others were already deferred to psych, patient decline in others. Primary team didn't want it in others. But the model's performance was only a small part of why this tool wasn't used. So this is another example of, it's great if you have a perfectly, a really sensitive model like we're showing here, but it's worthless if people aren't going to use it. And of those people that went on to use it, in those cases that a SUD consult was performed, Smart AI identified majority of those cases, and actually about 10% of them were attributable to the Smart AI system. So a little bit less than what I told you, where I think it was 20% in our health system. Again, I don't know if this is because we had a fully embedded AI system, which was really a lot more systematic and standardized than humans using the AI system to reach out to other humans. It was a little bit less efficient. But regardless, there were still a handful of consultations attributable to the AI system. And then some that were, there was, a number of false negatives, which again, that comes out to I think it's about 70-75% specificity. So at this second site, the composite outcome, similar, which is, like I said, looking at any form of medication treatment, Narcan dispensing, and so on. In 1,100 or 1,200 or so patients out of 31,000 hospitalizations, 3.8% usual care group versus 3.4% in the Smart AI group. Now here, this is the tricky part. So this was another non-inferiority design, but this was not significant. Actually, the non-inferiority margin was not, we weren't within that margin. The confidence interval actually, we set the non-inferiority margin at 5%, but the confidence interval, you can see, went from negative at 0.5%, 0.5%, went from down to negative. The lower bound was negative 0.7%. So we actually fell out of that non-inferiority margin and was not significant. How do we come up with negative 0.5%? There's no literature or evidence to guide us into what a lower confidence limit should be for a pre-specified non-inferiority margin of 0.5%. We just kind of made that up. So, take it for what it's worth. We had 3.8% of hospitalizations consulted for addiction medicine without the Smart AI system, 3.4% with the Smart AI system. But we didn't meet the primary outcome metric here. Interestingly, among the secondary metrics, when we looked at 6-month readmission, in this case versus instead of 3 months, 30 days, 6-month readmission also was decreased. And I don't know, it's hard to tease out the reason with this without doing a fully randomized clinical trial. But again, we did the same thing. The whole health system we looked at, and there wasn't anything that was happening at the time that led to readmissions. There was no reduction in readmissions in the health system. We adjusted for multiple other things, and we still saw this decrease in readmissions. What I can tell you in both these studies is that the AI system was identifying, there was a shift in identification. While the total proportions here look similar, there was a shift in demographics at University of Wisconsin to those with higher, those with more Medicaid, uninsured groups, more comorbidities, higher severity indices, and also later in the hospitalization, closer to discharge, where maybe the addiction medicine team was able to do more discharge planning with the care teams. We couldn't fully investigate that, but we're trying to, think of reasons why the readmission rates went down, and these are the changes that we did see without knowing exactly doing a clinical trial. Total program costs at this other second health system in Chicago is over a year of automated screening. We're about $6,000 less than doing manual screening, so it is cost effective over manual screening and those who did get the manual screening. decreased about $77 per unit change in outcome. That's the incremental cost effectiveness ratio. While excluding changes in cost of readmission, hospitalization post versus pre, this intervention, again, with those reduction of readmissions, that's about 15 readmissions avoided per, and that's about looking at 25,000 costs per readmission. That's, about 300, close to $400,000 in savings, potentially. And so that's, again, in this case, our health economists use the actual cost finance data from the health system, again, to kind of know what it costs them for their readmissions. So in conclusion, integrating AI-driven workflows directly into clinical practice, I hope there's some hint here that this study demonstrates that automated approaches can achieve some effectiveness compared to standard of care human-led workflows while providing the scalability that we seek in these AI systems. There's some evidence here for cost effectiveness and associations with reductions and readmissions. And AI-driven automation, ensures the screening remains available despite, weekend hours, nighttime hours, workforce issues. While there's always a possibility of selection bias. We did look at the fairness metrics. This is a standardized approach that is identifying and screening everyone, not just our services at Wisconsin, where there's ad hoc consultations where they may be picking and choosing who they want to get seen by addiction medicine service. This is a little bit more of a comprehensive, standardized approach. It takes a team, like I mentioned earlier. We had great biostatisticians, health economists, systems engineers, implementation scientists, ethicists, clinicians, informaticists, all part of the care team as well. And this was all funded by NIDA at the NIH. The QR code, again, gives you access to the full model and implementation Python script to run it, along with our papers that supported all the different steps in this 5-year kind of journey across these health systems. Thank you.
All right, thanks, Majid. Really appreciate that. Great, thorough overview and fascinating journey you all took. So we don't have any questions that were in the chat yet, but those of you who are on, please put your questions into the Q&A box or the chat, and we'll read those out. But while we're waiting for some of those to come in, I did have a couple of questions myself. So one of which, early on, you were just talking about the process it took for this to get implemented and all of the different stakeholders that you had to work with, which would make sense why a lot of these interventions fail because of how much work that this has. What was I'm kind of curious, what was the reception that you were getting from people in these different along the journey here to getting this implemented? Were people interested in wanting to do this? Was there bias just around SUD that you were coming up across? What was that? Tell us a little bit. Can you tell us a little bit about that?
That's a great question, Mark. And I would preface that my answer with saying, it's a big change management culture, right, approach in this. And so if you think of like the diffusion of innovation theory, our health system is I would consider our health system innovator, early adopters of these technologies and emerging tech, right? Then there are late adopters and mid-world people. And so I think depending on what your environment culture looks like, ours was very receptive. This is something they've been wanting to do. This was a gap that they identified in clinical practice. We actually have an internal, pretty advanced applied data science team on the operations side of AI engineers, AI ops, AI architects, who knew how to do this work. We were a good research team to work with them to kind of help them implement the model. So it was kind of like, in some ways, the stars were aligned for us. I felt very fortunate in this respect to be on a team that was capable of doing this work and motivated to do it. And so I think it needs to be, and this came from top down, right? It was a leadership kind of effect where the leadership wanted to do more of these types of AI interventions and systems and take the risk with studying them. And so that kind of came to surface in this application. Whereas the second health system, there was a lot of resistance there. Like we had a strong research team there and great co-investigators, but the operations team and the project management that was, we went through multiple meetings and the request and bill kept getting higher and higher and higher of what they want us to pay to stand this up. And it was obvious they were not ready or willing to do it. So two very different experiences, all a kind of a context of the setting and environment. So I give you these two, and I think across the country right now, all health systems look a little bit different in terms of not just their practice, but their readiness for AI. Which is why I was asking you questions about your guys' AI readiness before we start.
Yeah, no, these are great questions. Really interesting where people are on this spectrum here. So we do have a question that came in on the chat. And so this one was wondering whether there was feedback from providers, nurses on the potential burden of these AI referrals. So tell us a little bit about that. You're talking about how many of these BPAs came in,
Yeah,
all
yeah,
this stuff.
that's a great question. Yeah, and I didn't go into detail here, but it's detailed more in our paper, where part of these PDCA cycles is that we actually went and interviewed a handful of end users, not just the addiction medicine team that would receive the consult, but the actual end users, the hospitalist providers. It wasn't firing on nurses, it was only firing on people who could order the consult service. And so all the providers, APPs and PAs and physicians, we interviewed them across multiple specialties, surgery, neurology, hospitalist services, to get their feedback about would they use this BPA, what's the best way to get their attention on it, and all these things. And that's what led into how we then deployed it and kind of how we designed it. We should, and we didn't do follow-up interviews afterwards. We're just starting to do that now because the addiction medicine service wants to expand the scope of this BPA. Actually, it's been working well enough that they actually want to tie it into treatment and other things. And so we're starting those interviews again to figure out what's working, what's not. There's been a couple of missed cases where the BPA was firing, patient didn't get the consult, and actually the patient ended up not doing well afterwards. And so all that's kind of part of that surveillance work I talked about, and that's kind of the phase 4 of a clinical trial equivalent.
Okay, thanks. If there's more questions, please chat those in. I did have a few others as we're waiting for. One was, so you described kind of how you dialed in the model to kind of obtain the number of patients the addiction consult team could handle. And I'm kind of wondering, do you think that had any impact on your results as far as like, making it kind of not inferior and that sort of thing, or if it had any impact on the results?
Yeah, so one thing we did before we decided to deploy this was we did two things actually. One, we silent tested it. So we ran it in the background in our production EHR environment to make sure that with chart review, was it still doing what it's supposed to, making sure there aren't any bugs, doing kind of what's called software A/B testing, as well as making sure the performance is appropriate. But the other thing we did, Mark, was that we went to the addiction medicine team and said, look, this is what we're going to expect from this, at least estimation wise. You're going to get about 26 of these alerts, and it comes out to, it actually ended up only being like on any given day, maybe 1 or 2 extra consultations that would happen potentially. And so that being said, that they were, with the staffing that they had and the expectations that we set for them, they were kind of ready for it. Their main concern wasn't the volume, and that's the thing and when it played out, that was actually what ended up happening. The volume was as expected. Their main concern was they didn't know why they were being consulted from the BPA. Because you can imagine, Mark, an intern that gets this alert and like, okay, I'll order the consultation. And one of the PDCA cycles because it says one of the reasons you can put it is referral from BPA. And they're like, this is not helpful. Then we have to spend more time calling them and saying, so what is your actual question for us, and stuff like that. So we took that away and we modified it to allow them to order the cows, and also to make them put in a reason in addition. And so that seemed to help the addiction medicine folks.
Okay, all right. That is, yeah. The point around getting a consult where it's just the BPA would be would get a little bit annoying.
Yeah.
It makes sense that was.
Yeah.
One other question, another question that I had on this is, so as I was reading through this paper and on the Nature Medicine paper, and I think you mentioned in the talk here as well, is that the hours to consult were longer in the post-intervention versus the pre-intervention part of the phase. And I was wondering, one, what you make of that, and two, if providers were kind of getting dependent on the AI to kind of identify people at risk and put the consult in, getting a little bit clinically lazy maybe.
Yeah, so this is what we observed. So we did see that, and then we also saw a little bit of shift in the type of patients that had more comorbidities and things like that. And what we kind of were able to investigate a little bit on some of the chart reviews is that what was happening was that patients that, there's obviously, there are many obvious cases, right? Patient comes in after an intoxication overdose event, or they come in specifically with, withdrawal symptoms. And so those are ones that, like, yeah, they're going to consult the addiction medicine service right away. And the consultations happen early. But it's those cases that we notice that it's an older patient that's got heart failure and MI and comes in with a pneumonia, and they're being treated, their focus is on the pneumonia, but the BPA keeps firing because the underlying condition that they have, potential opiate use disorder, and that's not being addressed. And that's what happens in these hospitalizations is the physical ailment is a priority, the broken bone, the wound infection, and then the substance use is more of a kind of a secondary thought, right? And so we think that this BPA would just kept nudging and nudging and nudging until finally they would make that consultation order. And so that, I think that's what we were observing, is that the addiction medicine team was saying, yeah, we're getting these consultations a little bit later, but these are actually patients that just needed help to figure out how to manage their disease beyond just the broken bone that the trauma surgeon was focused on. And so that's what it turned out to look like.
Thanks. Okay, we do have a question here that came in. So the question is what is your method for addressing or minimizing the ecological impact of using AI?
The ecological impact?
Yeah, I don't know if the person who wrote this could expand that. Are you talking about environmental impact, or is there another something else you meant by environmental? Okay, yeah.
Yeah, so that's a great question. Let me put it in a couple ways. When we've done publications where we actually will give the carbon footprint of what it took to build the model, train the model. This model, so this is a static model that was trained once, and it was on a smaller kind of compute infrastructure that could handle this several million parameters. So the environmental impact of running the system is relatively low. The newer Gen AI systems, where these are huge models that are requiring tons of resources, and these GPUs, just to run them, they have fans that are this big, that the wattage is high, are expensive on our carbon emissions. And so, if anything, I would argue, like, there are certain systems that need that may provide the benefit over the risk of the environmental impact. But this is a case I didn't mention it, but we did look at large language models for opioid misuse just to see how it compares. And the difference was negligible enough that we decided that this small system that is cheaper and more efficient to run was worth the benefit than having a ChatGPT do this type of work for us, because it takes a lot more energy for it to do it. And it's kind of hitting a small nail with a huge hammer type of problem. So I think that's a great question. I think we need to be more thoughtful about how we use the spectrum of AI is big. And so there are systems that could be very catered and small and tailored to your task, versus some that require more, complexity that may need a large language model, which is going to require a lot more energy. This is not a large language model. This is, by comparison, a very small model.
Great, thanks. Great question. All right, let's see. I was looking for, it looks like one of my other questions, but maybe we can I have one other one, and you kind of alluded to this a little bit, but I'm kind of wondering about next steps. So it sounds like the addiction consult service is wanting to expand this a little bit. What's kind of, what are you working on next here?
Yeah, so without sharing too much, Mark, Elizabeth, which is one of our addiction medicine providers, she actually got a CDC grant to expand the scope of this work into the emergency department and start in an ED to help ED providers nudge them to do BUP initiation. My renewal, I told you my R1 is up. My vision now is, like, there's a lot of what we learned from this experience is a lot of people uncomfortable just treating, right, or managing these patients. And you don't necessarily need an addiction medicine service to come and do the BUP initiation. I think some of that can be managed by, we're learning, like, with the waiver going away and, like, more and more providers outside of addiction medicine coming in to initiate treatment. What if we actually had a full end-to-end AI system, what's called agentic workflows, where, okay, the screener identifies risk, then there's another AI agent that comes and walks you through DSM-5 criteria to ensure you establish a diagnosis. Then we have all these clinical protocols and guidelines in our health system and these PDF documents and these links. What if that can be actually incorporated to real practice as your digital twin or your assistant on the side? So when you're in the middle of the night in a busy ED, they can guide you step by step on how to initiate and start treatment and what to think about. And so I think the augmentation of AI into our workflows can really take off some of that stress and some of that cognitive burden to help really get us the delivery of care that we intend and scope that we want to catch in all these patients. So in my opinion, I really do believe there's a future where we're going to have a lot of these agentic workflows that augment us to kind of become not miss cases and do a better job at initiating treatment or delivering treatment when we may not be comfortable doing otherwise.
Okay, that sounds pretty exciting, and look forward to hearing more from you all as far as what's going down the road. All right, I think maybe that's all we have. And thank you very much for this talk. Appreciated people's comments, and Jed, I'll turn it over to you.
Yeah, I just wanted to hop back on and say thank you, Dr. Afshar. That was a great presentation today. Dr. Duncan, thank you as well for hosting. And everyone online, thanks for joining us. Like I said at the beginning, we don't have a grand rounds next week, but we will return in 2 Fridays from now. So please join us then. And everyone have a good Halloween and have a good weekend.
Happy Halloween. Bye.